Is everybody able to hear me if I don't use the mic? There might even be picking me up. I see some old friends over there. So we're going to talk about neonatal abstinence syndrome, but it's going to be a very quick run through just due to the limitations of time. But hopefully we can at least go over the signs and symptoms that are associated with neonatal abstinence syndrome, some of the drugs that we see that result in it. We're not going to go over all of the scoring systems, but we'll talk about the most common one, which is Finnegan scoring system or a modified Finnegan scoring system, and then go over treatment strategies. I think, do they have copies of the slides?
We will have it up on a website.
Okay. I won't go over a lot of the data, but the point of a lot of these slides are just that this isn't a new problem. This has been a problem for decades. And unfortunately, as we look at the problem with heroin, this isn't something that just came up in the last 5 years, 10 years since Vietnam. This is something that was created by a pharmaceutical company. So these guys were trying to do their best to make a less addictive medication, and unfortunately they came up with heroin, which, as we know now, is more addictive. But opioid abuse is a huge problem in Indiana, and it's becoming such that the drugs that the people are getting aren't just laced with heroin, or it's not just heroin, but they're also being laced with other narcotics like fentanyl, which are so much more potent and can lead to overdose in the people who are completely unexpecting that they're going to overdose. I mean, they aren't really even thinking about that, but you get the fentanyl on board and their respiratory drive just goes down, and unfortunately a lot of these people are dying, which is why our first responders are now being able to carry Narcan or naloxone out with them to temporarily reverse this until the drug gets out of the system. But it's a huge cost, not only from the treatment of the adults that are using and abusing the narcotics, but it's also a huge cost from the standpoint of neonatal abstinence syndrome. And one of the huge concerns that we have here in Northeast Indiana is that we don't see as many infants getting treated as we would expect because... Do you have a question?
You might want to define neonatal abstinence.
Thank you. So with neonatal abstinence syndrome, we're going to go over that in just a minute in terms of the symptoms. But when people are exposed to narcotics for an extended period of time, the body becomes accustomed to it. And when it's acutely taken away, then they have signs of withdrawal. And it's the sweating, the fidgetiness, the stools, vomiting, any number of different things, all the way up to seizures. And when we see that in the parents, we can also see that in the babies, because the babies are getting this drug through the placenta, and if they've been exposed to it throughout the course of the pregnancy, they're also going to have withdrawal after they're delivered because it's an acute removal of that narcotic. So just like the mom would withdraw if she stopped taking narcotics, the baby also can withdraw as a result of not taking the narcotics. And when we look at that, there's many other things that go into the formula of whether or not they'll withdraw. The placenta actually metabolizes some of the narcotic. The baby metabolizes some of the narcotic. So it's hard to say, when we've got moms that are on methadone, okay, we're on this dose. This mom's going to have a baby that's going to withdraw. She's on this dose. She won't. That's not actually the case. We don't know which level is going to be increase the risk for the baby. But we do know that if she's on that medication, there's a risk for it. So we need to identify the women that are exposing themselves and the fetus to the narcotics so that we can watch the baby after it's born for the neonatal abstinence syndrome or the withdrawal from the narcotic. The cost is huge when they end up getting admitted to the intensive care unit, $90,000, and that's for a typical 1-month stay in an intensive care unit. And that's, assuming that everything goes well and they get out in a reasonable amount of time. Sometimes these babies will be in the hospital for 6 weeks to 2 months in extreme cases. And those extreme cases are when it's not just heroin, or it's not just, if you guys can't hear me, just yell at me, I'll put the mic on. So we discharge these babies typically before they would show signs of withdrawal, especially if the mom's on methadone or buprenorphine. And those babies, they may withdraw in the first 48 hours of life, which is that point where we will oftentimes discharge the babies. But in the moms that we don't know that are exposed, some of these moms are being discharged at 24 hours of life, at 36 hours of life. So we're going to miss them. And then they're going to take this baby home. And we talked about, what the withdrawal symptoms can be, the irritability, the fussiness, the crying, the stooling, the diarrhea. All of these things can put the baby at risk for death. Or they can put the baby at risk for being shaken because the baby's so fussy and you've got this mom and this dad that are sleep deprived. And so unfortunately, they're going home without support, without identification, and support without the support of knowing how to care for this baby that's at risk for withdrawing. So these are many of the medications that are associated with drug withdrawals. It's not just opiates. It can be caffeine. It can be nicotine. We've all that have taken care of babies seen the mom that was a heavy, heavy smoker. You smelled the cigarette smoke when she walked in to deliver, and you smelled it when she came into the NICU. And she hadn't smoked in 2 days. So nicotine also causes withdrawal symptoms. We see these babies oftentimes very fussy for several days out to a couple of weeks. Alcohol can have symptoms, and we talked about the SSRIs, the selective serotonin reuptake inhibitors like Paxil. And fortunately, I will say, we haven't seen those types of patients in probably years at this point. About 7-8 years ago, we started seeing a huge increase in the number of babies that were being admitted to the unit because of withdrawal type symptoms. And the only thing that we could find was that the mom was on an SSRI. And after the black box warnings and after much more vigilance in terms of the specific ones that were being prescribed, we haven't seen these symptoms, and maybe we're missing them too. But they were having those symptoms pretty quickly. And the signs were the same. I mean, they would be fussy. They would have loose stools. Some of them would even have seizures. So it wasn't something that was able to be taken lightly. So neonatal abstinence syndrome, we talked a little bit about it, but where we see it now is when women are using drugs and abusing them, narcotics, or when they're in chronic pain management. And in these cases, some of them, may not need the medications anymore, but because they've been on it for so long, nobody thinks to say, hey, why don't we see if we can get you off of this? And sometimes they can and sometimes they can't. There's certainly very legitimate reasons for people to be on it. But because of that, we have to be aware that the child is going to be at risk for withdrawal. And the timing will vary. So when we look at heroin, and unfortunately the pharmacist is here, so he's going to be thinking, oh, those are way off. But roughly, heroin's going to be very quick out of the body. It's going to be, for the baby, we're going to see withdrawal signs in the first day of life. Morphine, it's also not as quick as heroin, but morphine is out of the body quickly as well. When we start getting to your drugs like methadone and buprenorphine, those drugs are made to last long because we only want to have to dose it once a day. So if it is only dosed once a day, it's probably going to last in the body for a long period of time. And it lasts in the baby's body for a longer period of time as well. So one of the things we know is that the moms that are on these medications have babies that are at risk for withdrawal. What we don't know is which mom is going to have the baby that's going to withdraw. And unfortunately, what we've seen in the past, and it's, there's no blame being put on anybody, but what we find out is that the moms come to the nursery and they say, when we tell them that their baby is going through withdrawal, well, my doctor told me that I wasn't going to have withdrawal symptoms, or the baby wasn't going to have withdrawal symptoms. And the fact is that the majority of them don't. And so the majority of the time, they're right. But unfortunately, some of them do, and they're all at risk for it. And when we say that they won't have withdrawal symptoms, they may not have withdrawal symptoms that require hospitalization and require treatment. But as we showed in a previous slide, somewhere in the range of 40 to 90% of these babies will actually have signs of withdrawal. So when we look at how we treat these babies, one of the things that we talk about is, well, let's let them breastfeed, especially if they're on something that we consider relatively safe, methadone, buprenorphine. Certainly we wouldn't do it with things like heroin, or if we knew that they were a polysubstance abuser like cocaine or spice. The nice thing is that with this, it's not because the baby's getting a huge amount of methadone. That's one of the misconceptions about breastfeeding and methadone and buprenorphine, is that the amount of the drug that the baby gets is small, But after it goes through the gut and gets metabolized by the baby's liver, that amount is even smaller. Any thoughts on other things there? I mean, are there other medications that are more likely?
More likely to be excreted through the breast milk?
And is heroin, I mean, not that we're going to tell the mom to go ahead and breastfeed on heroin, but...
all of the narcotics do a little bit of liver as well as serum metabolism.
Okay.
So methadone is the one that tends to be the least amount getting there because of all the first pass and liver metabolism.
Yeah. So what we find is that it's not the drug that's getting to the baby that's causing the baby to be calm. It's the comfort measures that are associated with the breastfeeding, the soothing that's associated with the breastfeeding, the bonding that's occurring as a result of the breastfeeding. So we want to encourage these women, so long as we know that they aren't using other medications or other drugs, to go ahead and breastfeed, because it's going to promote a healthy diet for the baby, it's going to promote a healthy practice for the woman, and it's going to promote that bonding. And these babies and the moms are already at risk from a couplet standpoint for having complications. So we want to encourage that bonding so that we don't end up splitting the family apart. I promised I wasn't going to talk long, and I'm already talking longer than I'm supposed to. I'm sorry. So we'll skip over some of these slides, but just know that when the women are using drugs, there are other things that we need to be looking for, whether it's abuse from a significant other, or whether they're being sexually abused, or whether any number of different things. So you need to look deeper into the background of these families. So drug testing. Meconium is our old gold standard because all babies poop, and we can send it off, and it's going to check what the baby has been exposed to in utero for about 3 months or so, certainly during that last trimester into the end of the second trimester. The problem with that, unfortunately, is that all babies poop. Some babies poop before they're born. And so then when they deliver, all that meconium's already gone, and they've already got transitional stool, and it doesn't really help us a whole bunch. And so one of the things that we've used is urine and umbilical cord. There have been extreme cases where we've actually used hair. In the case where we didn't have the umbilical cord testing, we didn't have the meconium anymore. The urine was already passed, and you can only cut so many nails off of a baby, and you still won't get enough sample for it. So you can shave the hair off in those extreme cases, but you need about a pencil width clump of hair for it. Umbilical cord, though, is always there. We're always going to have a piece of umbilical cord. So what we're working on now is having the standardized protocol around the region, and certainly in the state, to have a piece of umbilical cord at least available for testing even after the baby's discharged from the hospital. So out to about a week. Some places are considering saving it for 2 weeks, because in these cases, the baby goes home at 2 days of life, isn't showing signs of withdrawal, but comes in to see the family medicine doctor or the pediatrician at a week, and the mom says, he's just fussy all the time, I can't take it. The family medicine doctor may say, well, you're a little bit on edge. Are you telling me everything? And maybe they suspect that there's been some drug use in the mom. They can call back to the hospital and say, do you still have that segment of umbilical cord on this baby? And then they can go ahead and send it, and within 2 days to 4 days, we should have a result back, depending on which lab that we use. So breastfeeding, heroin, cocaine, definitely no. Methadone, yeah, it's okay. So withdrawal, it affects the central nervous system, the autonomic nervous system, the GI nervous system, but treatment. So prenatal counseling, if we can get people to start asking about this before the mom gets pregnant, that's great. If we can get people to start asking about this after the mom comes in and identifies as being pregnant, that's great. It's not as good as getting it ahead of time, because we'd like to get the mom healthy before she actually gets pregnant. But during the pregnancy, what we need to work on is teaching these families, not just the mom, but the father or the significant other or the parents of the mother, how to deal with a child that's born after being exposed to narcotics or other substances, and get them trained with these soothing mechanisms, get them on board with breastfeeding. We don't want to have a mom come in and say she's going to be bottle feeding when if she would have known that we could have prepared her for the mental challenge. And I've never breastfed, but my wife did, and it's obviously a huge strain, because you're up every 3 hours. You can't just pass the baby off to dad and say, here, you feed the baby now, because the baby will be really grumpy after that. Haven't tried it again. But it's hard on these families, and so they aren't wanting. A lot of them aren't wanting to breastfeed, and they're saying that we're going to bottle feed. But if you can get them on board ahead of time, you're going to be more successful with that. In addition to that, you can also do some screening for the other comorbidities. If they're IV drug abusers, you want to check them out for HIV. You want to check them out for hepatitis. And if they've tested positive for HIV, there are other protocols that will go into place to help treat the baby and prevent the risk of the transmission of HIV to the baby. And so if we aren't even asking these questions, we're gonna miss so many things that can impact the life of this child, of the parents. So supportive therapy has to begin before the baby's born. And it has to be the prenatal counseling. It has to be setting these expectations for the families, not just how to comfort and how to know when the baby's withdrawing, but understand that the baby may withdraw to the point where it needs to be hospitalized for 2 to 6 weeks. And if they have that expectation, we're going to be so much more successful at working with the families when they come in. Because if you have a mom that's using narcotics, especially if they're using them illegally, or if they even have a history of having used them illegally, but they're clean now and that they're on buprenorphine or they're on methadone, and then you come into the room and say, Mrs. Jones, I'm sorry your baby's going through withdrawal. We're going to have to admit it to the locked neonatal ICU. Only a couple of visitors will be in there, at a time. What's that mom going to think? They're going to take my baby away. And all of a sudden, all the ability to work with that family, takes a nosedive. So we want them to understand before the baby's born, there's a chance the baby may be admitted to the NICU. And there's a chance the baby will have withdrawal symptoms and may even need to be put on narcotics itself for a period of time as we withdraw during this 6-week period. If they know that ahead of time, they're going to be much more likely to be comfortable working with us. Other things, swaddling. We want them to, know that they can wrap the babies up. We want them to know that having me talking really loudly in the room isn't a good thing for the baby because the baby's going to be jumping every time I raise my voice. So we want them to know that a quiet, calm, soothing environment, low-light environment is going to be helpful. And also, these babies talked about how they pass stool very frequently, and they're not just moving it through and using a lot of calories because they're moving it through their body, but their metabolism is so revved up that they're also using these calories for their metabolic rate. So they're going to need a lot more calories, and so they may eat every 2 hours. They may eat a little bit more frequently than that, but it's not because when the mom goes to the WIC office and says I ran out of my formula. This baby probably did because it's eating a lot more than maybe twice as much as an otherwise healthy baby would. So we have to have those expectations. We need to let the parents know that that's to be expected, and that you want to make sure that you're giving the baby those calories so that it doesn't have a low blood sugar, it isn't more cranky because it's starving, and also the baby's brain is developing so quickly during this period of time that we want them to be able to feed that baby's brain so that the challenges that come with the baby exposed after it starts to get older are minimized to that extent. And most of all, when the baby's in the hospital, we don't want to discharge these babies at a day. We don't want to discharge them at 2 days, really. We don't want to discharge them at 3 days. If we can keep them 4 days to 5 days, I think every one of the pediatricians and neonatologists would be ecstatic in town. We've worked with our friends over at Parkview. Dr. Rice and I are sort of tag teaming these types of projects and trying to really get a standard set up for Northeast Indiana. And with the Patient Safety Coalition, we're hopeful that we'll be able to identify what the real problem is in Northeast Indiana. If anyone recognizes these pictures, this is Jack Black. It's in Tropic Thunder. And I always put this up, and I always promise I'll never show it again. But I love the movie so much that I start crying from the moment that it starts rolling. It's very slapstick humor, but anyways, Jack Black is hooked on heroin, and he's withdrawing. He had tied himself to a tree because he didn't want to have to, run off and find that stash that was down in the drug camp. The point is that these people have very, very strong drives to get narcotics, and we have to understand that with our patients, and we have to understand that despite that, our newborns are going to be at risk. And we have to understand where the parents are coming from, so we can treat not just the baby, but the mom and the baby and the significant other. So we went through it really fast and skipped over a lot of stuff. What questions can I answer for you? Yes.
If the umbilical cord is so much information,
Mm-hmm.
is it that expensive to just routinely test your constant cord? It seems to be a logical test to just do when the baby's born, period.
It would be. The test, number one, the test for meconium is about $140 to $155 per patient. The test for the cord is about $165 to $175 per patient, and that's if you have a good contract with the company. And other companies are more expensive. That's with USDTL, U.S. Drug Testing Laboratory. The turnaround time for the umbilical cord is pretty quick. So theoretically, we could have these results back before the baby's discharged, especially in the ones that we know are at risk and we want to keep a couple of extra days.
Just in the overall picture of what my kids will take their babies, I don't know what it costs around here, they live in Chicago, but $150, and they were charging more.
Yeah. Oh, yeah. And that's the cost to the hospital. I'm sure the hospital will charge $500 for it.
But I'm just the overall cost of something like that. Always a benefit.
Yeah.
I'm not a health.
It's actually a discussion that's come up, and it's come up at the Northeast Indiana Patient Safety Coalition. It's come up at the state level with the neonatal abstinence pilot program that they're doing. What the state attorneys have said is that they would steer people away from doing universal screening because they don't want to have to deal with that legal challenge. Ideally, we would have that information, and we probably could do it, but just be ready for a potential challenge from somebody. The way that a lot of places are doing right now is they're doing universal questionnaires or universal verbal screening on the women during the pregnancy. If the mom tests positive with that verbal screening, they want to do a urine screen on her. If the urine screen is positive, then obviously the baby's going to get tested. Because the baby's at risk, we have a reason to test the baby. If the mom declines to do the verbal screen, there's a potential risk there, so we have a reason that we can test the baby. If the mom tests positive with the verbal screen, but she's tested negative with the urine, there's a potential risk there, so we can test the baby. So there are a lot of doors that are open to testing the baby beyond just the traditional things that we would see with like late prenatal care or no prenatal care. A past history of substance use, even though there's no history of it during this pregnancy. Many different things. So in an ideal world, yes, we would test everybody. And it would make, I'll go back to the neonatologist in town. It would make my colleagues over at Parkview and my colleagues at Lutheran, very happy to know that information on every one of the babies.
I would think ultimately it cost saving because the detection is really not the
Yeah.
I think that the real danger is that, they'll lose the custody of their children if they come up with a positive test. So,
And that's
that's
routine type thing.
which is
There's a lot of other
probably
things done that
a little bit overbearing to be taking away a child for a single positive test. So I think there's some negotiation that needs to happen on that end as well.
Yeah.
We've been in discussion with.
Yeah, in Tennessee they actually did that, and what they found was that a lot of women stopped going to healthcare providers. And so there's been legislation that's passed around where if the mom tests positive, that the OB or the family medicine doctor do not have to report that to protective services. But again, if we test the baby and the baby's positive, we are obligated to pass that on.
How many of these moms are going to prenatal care? If you're addicted to heroin or cocaine and you're living in and out of different houses, couch surfing, homeless shelters, I just, call me a naysayer, I don't think they're going to prenatal care appointments. They're the ones that are showing up in St. Joe ER with no prenatal care.
And those are the ones that are the moms getting the urine screen and the baby's getting the meconium or the cord screen sent.
I just think there's a lot more. I think that was kind of our stereotypical model of a drug user, but I don't think that is an accurate. Anymore, I think that the spectrum of people who are using drugs is so much more broad and unpredictable that one of our residents actually explored using the inspect. You guys know what the inspect is? We're filling legal prescribed narcotics or controlled substances, and it'll check Indiana plus a few other states if you check that option. And they kind of looking at the inspect compared to doing the expected results from a urine drug screen, and came up with 17% of the women that they checked had a positive inspect. They filled a controlled substance and they were otherwise unaware of it. And wouldn't have known about it.
And that matches what they found in the pilot studies in central Indiana, is that about 20% of the screens that they did were positive for some sort of illegal substance. And one of our OBs with Women's Health Advantage has a colleague in Atlanta, and in the Buckhead area, which is the very affluent area of Atlanta, about 10% of the women that were pregnant there were positive, unknowingly positive for illegal substances or prescription drugs, but weren't reported. So it again, just like Dr. Dawson said, it's not just a problem with the stereotypical person coming in. It's everyone that is at risk. And if we were to pigeonhole, this woman looks like a drug user, we're going to miss the one that comes in the nice dress and the pearls, and and she's just as much at risk, but she's got a little bit more access to the funds to get it. So we have to take it all seriously.
Thank you very much. Thank you all of you too.